Hello again, my name is John Tsai from the UCI School of Medicine, and today's video we will be continuing our physiologic journey through the kidney by talking about how our kidneys create the optimal pH for our body to continue to function optimally. To review, we have talked about salt and water regulation as well as the corticomedullary concentration gradient in our first video. We then talked about potassium regulation in our second video, and in this video we will be discussing acid regulation. In our next video, we will be discussing how various hormones are produced or play a role in the kidney, aside from its functions that we have described in the first three videos. While you will also learn about acid regulation in your pulmonary block, the renal acid handling is unique in that it is able to handle non-volatile acids, or acids that cannot be converted into carbon dioxide and be excreted through our respiratory system. Let's first start by recalling where all this acid that we have to get rid of actually comes from. Acid is generated as a byproduct of our nutrient metabolism. As you recall, carbohydrates and fatty acids are generally broken down into carbon dioxide, and when excess amino acids are broken down, they get converted into urea and other acids such as phosphoric and sulfuric acid. Carbon dioxide is considered a volatile acid since it can be excreted as a gas, unlike sulfuric and phosphoric acid, which are non-volatile acids and cannot be excreted as a gas. The chemical equation here showing the combination of carbon dioxide and water to form carbonic acid through the action of carbonic anhydrase, which then gets broken down into proton and bicarbonate anion, is a very important equation that happens throughout our body. Obviously, we are continuously producing carbon dioxide in our cells through our metabolism. The carbon dioxide gets dissolved in water and forms carbonic acid, and it is this proton and bicarbonate that is soluble in the serum, then transported around the body to the lungs and the kidney, where this chemical equation can be reversed. Once the dissolved carbon dioxide reaches the lungs, it is then released into the air. Since we are generating a lot of non-volatile acids in our body that can't just be excreted through the lungs, we must have a buffering system to prevent the buildup of this acid and the resulting damage an acidic environment would cause to our cellular functions. While our cellular functions can adapt to fluctuations in pH, the pH range that cells can function properly is roughly around 7.4, but with the extremes of life capable of handling a pH from about 6.8 to 7.8. Interestingly, our cellular functions and systems are much more capable of tolerating lower pH values or acidic environments compared to higher pH or alkalotic environments. The most important and most abundant buffering system that we have in our body is a bicarbonate/carbonic anhydrase, carbonic acid buffering system. The bicarbonate anion that is produced in our kidneys, which we'll discuss later, is integral in mopping up the extra protons that we have that are being produced as acidic byproducts of metabolism. These non-volatile acids are then eliminated by different mechanisms in the kidney, and the bicarbonate is reabsorbed or regenerated to continue its buffering role. Along with the bicarbonate carbonic acid buffering system, we also have the ammonia system in our kidneys, protein and phosphate buffers, as well as hemoglobin that can act as a buffer as well. As a nephrologist, I like to think that the kidneys are the most important organ, but I have to hand it to our pulmonary colleagues on this one. The lungs have a much higher capability of handling acid compared to the kidneys and can affect pH values much faster compared to anything that the kidneys can do. Gas exchange is just so much more efficient compared to generation of bicarbonate and secretion of acid through the kidney, and it shows from these numbers here. The lungs can excrete about 12 to 13,000 millimoles of acid per day, compared to the palsy's 70 to 100 millimoles of acid per day that is excreted through the kidneys. During exercise or stress, even higher amounts of carbon dioxide can be generated and exhaled through our kidneys, upwards of 20 to 25,000 millimoles per day that our lungs are capable of handling. But as I said before, the kidneys are able to handle the non-volatile acids that our lungs cannot, and the two organs work together to effectively and efficiently maintain the acid-base balance throughout our body. Our kidneys generally play three important parts in acid-base balance. The first is that it recaptures all of the bicarbonate that is freely filtered through the glomerulus. The reabsorption process is similar to sodium reabsorption, where upwards of 80% of the filtered bicarbonate is reabsorbed in the proximal tubule. The remaining 20% is reabsorbed through the thick ascending limb of the loop of Henle, the distal convoluted tubule, and the collecting duct. In addition to reabsorbing the bicarbonate that is filtered through the glomerulus, our kidneys are also important at playing a role at generating new bicarbonate through the breakdown of the amino acid glutamate. Lastly, our kidneys also manage acid loads by directly excreting fixed acid in the cortical collecting duct. I'll go over each of these processes more in depth in the coming slides, but realize that if any of these become problematic, any abnormalities in these processes will eventually lead to retention of acid in the body and the development of what we call acidosis. Let's first talk about the reabsorption of bicarbonate. And remember that most of the process happens in the proximal convoluted tubule, accounting for about 80% of the bicarbonate reabsorption. First, the filtered bicarbonate combines with a secreted proton from the proximal tubule cell and gets converted into carbon dioxide and water through the action of carbonic anhydrase 4 enzyme that is found on the luminal membrane. The carbon dioxide and water are able to freely pass through the cell wall into the proximal tubule cell, and then it gets converted again into a proton and bicarbonate ion through the action of carbonic anhydrase 2. This enzymatic activity lowers the carbon dioxide concentration in the cell that allows for more diffusion of carbon dioxide from the lumen space. Next, the bicarbonate anion then exits the cell into the blood space via the sodium bicarbonate transporter NBCE1. The proton gets excreted either through the H+ ATPase or the sodium hydrogen exchanger NHE3 that we had previously discussed as a method for sodium reabsorption in the proximal tubule. Then the cycle repeats itself over and over again. In the distal convoluted tubule and other areas of the nephron where bicarbonate is reabsorbed, the same process occurs, but at a lesser degree compared to the proximal tubule. Now let's talk about how we generate new bicarbonate that is used to replenish supplies that are lost. New bicarbonate is generated through the metabolism of glutamine, the most abundant amino acid in the body. Glutamine metabolism actually results in two very important things. The first, of course, is bicarbonate, but the other is ammonia, which is just as important as we will see in the coming slides. For each glutamine molecule that is broken down, 3 bicarbonate ions are created and are transferred into the blood by our good friend, the sodium bicarbonate transporter NBCE1. The ammonium NH4+ ion is then either directly transferred into the urine space by the sodium hydrogen exchanger NHE3, or alternatively, the ammonium NH4+ ion can be separated into a proton in ammonia, which is then transported into the luminal space via similar mechanisms. The details of ammonia or ammonium secretion are not necessarily important, but know that ammonia is secreted into the luminal space and will eventually act as the main urinary buffer, preventing our urine from getting to such a low pH that would destroy our bladder. Lastly, our body can get rid of any extra protons in the distal tubule via 2 mechanisms in the alpha intercalated cell, the H+ ATPase and the H+K+ ATPase. The hydrogen potassium or H+K+ ATPase is dependent upon potassium secretion from the ROMK in the principal cell. The ROMK in turn is dependent upon sodium reabsorption through the ENaC channel. And the ENaC channel is in turn dependent upon the presence of aldosterone. Hence, the proton secretion through the proton H+K+ ATPase is ultimately aldosterone dependent and will play a role in states of high or low aldosterone, as we'll see later. So we can see here that in states of high aldosterone, this increased sodium reabsorption, which then increases potassium secretion via the ROMK, the extra potassium then stimulates the H+K+ ATPase in the alpha intercalated cell to secrete protons, helping to eliminate extra acid from the body. We can also see that if aldosterone is high, we can also see that if high aldosterone is present, either pathologically or due to high potassium levels in the body, then a secondary effect will be proton secretion, leading to lower acid levels in the body and a higher bicarbonate level in serum, a state that is known as metabolic alkalosis. Let's go back to ammonia, and I want to preface this slide by saying that we don't know the exact mechanism behind the entire process, and much of this may sound very hand-wavy. All you should remember is that ammonium is secreted by the proximal tubule after it is created, as we had discussed before. The ammonium is then reabsorbed in the loop of Henle into the interstitium, and then it gets re-excreted in the distal tubule in order to help reabsorb the protons that are secreted in the cortical collecting duct, as we had discussed in the previous slide, via both aldosterone and non-aldosterone mediated channels. Essentially, ammonia somehow plays an important role at helping to buffer the urine to allow additional proton secretion from the distal tubule. I also want to say that in addition to ammonia, phosphate buffers also play an important role in urinary acidification systems. Its physiology is also unfortunately not well defined either. I am putting a link to the Deranged Physiology website down below that discusses the process of ammoniogenesis and ammonia cycling if you want to know more about this process. Now, I just want to go over what happens when we have any derangements in any of the physiological processes that we just talked about by talking about an important physiological issue called renal tubular acidosis, or RTA. If we have any issues with the reabsorption of bicarbonate in the proximal tubule that results in bicarbonate not being reabsorbed either through the NBCE1 transporter or the NHE3 channel, we call this a proximal RTA, or type 2 RTA. This is called type 2 non-intuitively since it was the second type that was discovered. Now, if we have a problem with proton secretion in the distal tubule or the alpha intercalated cell, either through the H plus ATPase or the H plus K plus ATPase, then this is called a type 1 or distal RTA because it is in the distal tubule. And if you have a problem with ammoniogenesis, or if you have an aldosterone issue, either in the production of aldosterone or resistance to high levels of aldosterone, then we call this a type 4 RTA. There is one additional type of RTA called a type 3 RTA that was discovered to be a combination of type 1 and type 2, which is due to defects in the carbonic anhydrase 4 enzyme found in the luminal membrane that is common to both proximal and the distal tubule. Hence, this is really a combination of the two types and not technically considered one of the proper RTAs anymore. This table summarizes all the electrolyte findings into three types of RTAs. Remember that all of them will produce varying degrees of acidosis, so the serum bicarbonate will be low. In addition, since the proximal and distal tubule are also important in reabsorbing potassium, type 1 and type 2 RTAs will have low potassium levels of hypokalemia, while type 4 RTAs will have high potassium levels since there is usually aldosterone resistance or insensitivity preventing adequate potassium excretion in the distal tubule. For this reason, type 4 RTAs are also called hyperkalemic RTAs. Now, why does type 1 RTA have a lower bicarbonate level but a higher urine pH compared to type 2 RTAs? The reason for this is because proton secretion is impaired in distal or type 1 RTAs, but not in proximal or type 2 RTAs, which allows for the urine acidification to occur. There are actually some slight variations of these RTAs that can occur, but this high-level overview will be the extent to which you are responsible for this information right now. Now, how can we find these cases of renal tubular acidosis? These are actually fairly rare, but potentially if you look for them, you may find them that they are more common than you expect. The first clue is to look for low bicarbonate levels. Low bicarbonate levels can mean one of two things, either a metabolic acidosis or a respiratory alkalosis when the kidneys compensate by eliminating extra bicarbonate from the body, resulting in a low bicarbonate level. We can use an ABG or VBG to confirm the presence of a metabolic acidosis or a respiratory acidosis in ways that I won't go into in this lecture, but I'll put a link to another talk that goes in depth on this and how to read and assess blood gases down below. Once we have determined that we are dealing with a metabolic acidosis, the next step is to determine if you have a high anion gap metabolic acidosis or a non-anion gap metabolic acidosis. We calculate the anion gap using the serum sodium, serum chloride, and serum bicarbonate. And if that equation is higher than 12, then we are usually dealing with a high anion gap metabolic acidosis. If the value of the equation is 12 or lower, then we are usually dealing with a non-anion gap metabolic acidosis. Once we determine we are dealing with a non-anion gap metabolic acidosis, then we can calculate a urinary anion gap, which is the urine sodium plus the urine potassium minus the urine chloride. If this value is negative, then it is most likely a GI cause for your metabolic acidosis. Whereas if the urine anion gap is positive, then we are usually dealing with a renal cause, possibly an RTA in this case. So you can see here that there's a lot of steps to formally diagnose somebody with an RTA. And once you become more familiar with these laboratory tests, it does get easier and easier with practice. I also wanted to stress that RTAs are usually due to channelopathies or tubular issues in the absence of chronic kidney disease. The presence of chronic kidney disease is usually associated with a metabolic acidosis for the sole reason that there is low nephron mass, resulting essentially in all the different RTAs and not a specific RTA in particular. Hence, please ensure that the patient has a normal renal function before diagnosing any RTAs. Let's review today's material with another diuretic that we use called acetazolamide. Acetazolamide works by blocking the carbonic anhydrase enzyme in the tubule, especially in the proximal tubule. It works as a diuretic because bicarbonate usually is associated with a sodium molecule in solution, and if we aren't able to convert bicarbonate to carbon dioxide and water, we get bicarbonate wasting or bicarbonaturia, basically bicarbonate in the urine. This results in distal sodium delivery and eventually sodium wasting, leading to its diuretic effect. Now remember, if we block carbonic anhydrase, this will result in a type 3 RTA that I discussed before, since it acts in both the proximal and distal tubules where carbonic anhydrase sits, and it eventually will lead to a lower bicarbonate levels in the blood, hence the acidosis. This is a medication that we don't want to use on somebody with normal issues, but in the case where we have high bicarbonate levels in the blood or alkalosis, you can actually see how this medication would be very helpful to correct this alkalotic state and bring the pH back down to more normal levels. Now I want to talk about a physiological state that we can use this interesting medication on the next slide. One other use of acetazolamide is in prevention of altitude sickness. How does this work? Low partial pressures of oxygen at high altitude levels induce hyperventilation. As you may recall from your pulmonary lectures, hyperventilation results in lowering of the PCO2 levels in the lungs and in the blood, which in turn causes a rise in your pH. Usually, your kidney can help compensate for this rise in pH by getting rid of excess bicarbonate. However, this kidney process lasts on the order of 3 to 5 days. This is the main reason why acclimatization to high altitude is necessary for your body, and you should usually go slowly up a tall mountain. However, there are some situations where you just can't wait, such as a direct airplane flight from a low altitude area to a high altitude area. In these cases, acetazolamide can help by basically bypassing your body's slow response to low PCO2 levels. Acetazolamide induces a metabolic acidosis by getting rid of bicarbonate so that when you go up to higher altitudes, your pH levels don't rise to levels that will cause you to feel ill. The induced metabolic acidosis is also helpful in that it increases ventilation and oxygenation in the body to compensate for the low oxygen concentrations at high altitude. There was a lot of material that we covered in this video and in previous videos, but let's summarize with a case study with when medications we give can cause more problems than we are trying to fix. Cisplatin, a chemotherapy agent used in many different forms of cancer, and tenofovir, an antiviral agent used in the treatment of HIV, has a known side effect that can cause damage to the proximal tubular cells. This destruction of the proximal tubular cells results in a lot of different electrolyte derangements, since, as you recall, the proximal tubular is responsible for reabsorption of 60 to 70% of all the electrolytes that are filtered through the glomerulus. Knowing how the filtrate is now processed from the proximal tubule all the way to the distal tubule, you can predict what happens to sodium, bicarbonate, and potassium levels in the body when these medications do cause damage to proximal tubular cells. So pause the video here to think about this case, and then click play when you're ready to hear the answer. The destruction or inhibition of proximal tubular cells causes a constellation of issues called Fanconi syndrome. And if you remember what the proximal tubular cells do in the kidney, then you can predict what the effects are for Fanconi syndrome. With regards to sodium levels, it does result in sodium wasting, but remember that we have the loop of Henle in the distal tubule to make up for this sodium reabsorption problem, so we don't usually get any issues with sodium levels in the body. When it comes to potassium, Fanconi syndrome can also cause problems due to potassium wasting and can cause hypokalemia. With regards to bicarbonate, Fanconi syndrome causes a type 2 RTA, which results in low bicarbonate levels in the blood. But since distal proton secretion remains intact, the pH of the urine remains low due to our distal proton secretion processes remaining intact. Additionally, proximal tubular abnormalities cause glucose wasting or glucoseuria, phosphate wasting or phosphaturia, and sometimes proteinuria, which are all hallmarks of Fanconi syndrome. That's all I have for you in this video, and as usual, I am leaving you with some additional resources for you to learn more that I'll also put in the description below. Please join me in my next video when we'll be discussing hormonal aspects of renal function.